What we're going to do now is we're going to walk you through those little physical exam pearls and show you a thumb spica and how to put one on. Okay, so now we've shown you those cases. We're going to review the physical exam and we'll show you how to put on a thumb spica and talk about some of the nuances and some of the options that are available to us. If we go back to the physical exam, the starting point of the wrist exam is Lister's tubercle. It's a little bump on the distal radius, that's here. Ulnar styloid is here. If I hold Lister's tubercle and move his wrist up and down, my examining thumb and finger don't move. But from Lister's tubercle, what we want to do, there's his second web space. Just come down a little bit and you'll feel a small little divot. And that's the scapholunate ligament. That's where they're sore. And I never touched it before. Most of us probably don't. But if you start touching it, you'll find patients, young adults, fall an outstretched hand tender here. And that's when you add the clenched fist view. What else do we know? We know about snuffbox tenderness. So if he hikes up his thumb, we can find his snuffbox. But we don't want him to hike up his thumb when we examine it because that puts the wrist in radial deviation. So once you know where it is, right, there's his snuffbox. So that's where you would examine for. And the best way to do it is just to hold onto his hand this way, put his wrist up. Now his wrist is in ulnar deviation. I can press. If he says it hurts, I will compare it to the opposite side because about 20 or 25% of people, sometimes up to 30, have pain that's just, it's physiology, not pathology. So compare and see if it's different. That's snuffbox tenderness. Palmar scaphoid is right here. And the third test is axial his first metacarpal. When you axial the first metacarpal, if that causes some pain here, that's another sign that he could have a scaphoid fracture. Those are the 3 clinical tests we use for a clinical scaphoid. So if we're worried about scaphoid, he's getting a thumb spica. Scapholunate, he gets a thumb spica. If the injury comes more distal, then we have to make some modifications. If he's got an ulnar collateral ligament injury of his thumb, this is here at the first MCP. Right? We talked about the fact that you need to know whether it's a grade 1, 2, 3 if the x-ray is negative. What you need to know is what is normal for him. So again, we'll take his normal thumb ligament, flex about 20, 30 degrees, and then just see how much it opens, and you get a sense of it. And now when I come to this side, if he says that hurts, but it opens the same, that's a grade 1 injury. If it opens a little compared to the opposite side, but has a definite endpoint, that's grade 2. And if it just goes way wide, there's no endpoint at all, that's a complete tear, and that means surgical repair. So 1 and 2 are non-operative. We need to put a splint on it. A grade 3 will temporize with a splint, but we need to get them in the hands of a surgeon. And then sometimes you can have a fracture along the phalanx. It could be the first metacarpal, proximal phalanx, distal phalanx, but a fracture somewhere along the thumb, that also would warrant a thumb spica splint. So now we're going to talk about putting on a thumb spica. There are various options for it. If somebody has a suspected scaphoid injury or a scapholunate ligament, we just need to rest the thumb. We need to rest the wrist. Options include a removable splint, which is fine as long as patients are compliant. If they take it off, not compliant, go back to sport, don't follow up, then they can be lost to follow-up and it can be an issue. So you need to have good advice with patients, but this is certainly appropriate for suspected scaphoid fractures or clinical scaphoids and for a scapholunate ligament, as long as your surgeons are happy with this as an option. Also as an option, you could use something that has it's fiberglass. It's pre-made fiberglass splinting. Fiberglass is not great for molding. But if you suspect they've got a scaphoid fracture, if they have a definite scaphoid fracture, if they have a scapholunate ligament injury, fiberglass is fine because molding's not important. But once you start getting into the fine details of a thumb, you need to mold a fracture or you need to mold the position for scapholunate ligament, it's easier to do that in plaster. And you can certainly do all of this in plaster, so we'll walk you through this. If we're going to put a splint on, one important thing to do is just to make the patient comfortable first. Get your materials ready, and we'll walk you through the process of putting on a thumb spica splint. Now, what do we need for it? Most ortho books they talk about using stockinette, but from an emerge perspective, an emergency department, it's not necessary, so we actually don't use stockinette. You need something to protect the skin, so you need padding. It comes in different widths. Basically, take the patient's hand, whatever size roll fits in their hand, that's the right size for the patient. If they have a really big hand, use 4 inches or whatever the size that fits. If it's a kid, it might be 2 inches. Don't memorize, customize the right size. So you need padding to protect. You need strength from a splint, so that's plaster. These dispenser boxes come in 5 layers. Typically, we'd use 10, so whatever length is appropriate, we'll double it over to make 10. We'll talk about how to measure in a minute. but we have plaster available in different widths. Because it's a splint, it's non-circumferential. You need something to hold it down. Ace bandages tend to be too tight. We tend to apply them too tight, these compression bandages. So what works really well is cling. It's used over kids' bandages. It conforms very nicely. We use this over all of our upper extremity injuries. It's actually quite wonderful. We'll show you how to use that. You need water, because that's how you get the plaster, you get it activated. So it requires water. You need tape to hold it down, tear off your tape. Otherwise, you're calling a nurse stat to the ambulatory care area to get this looked after. And then you're ready to go, and a pair of scissors, of course. Now, let's talk about the splint itself. How far do we go? What are our proximal and distal ends? Take the long bone. So this is his radius from here to here, and divide it into thirds, essentially. And what you want, this is the distal third, the middle third, the proximal third. The splint has to go to the to the proximal third of the forearm. So this is the proximal aspect of it. Padding will go past it, but the plaster is going to go to the proximal third. How far down does it go? If it's scaphoid or scapholunate ligament, we can stop at the IP joint. So that's how long it's going to be. That's what we'll show you now. But if it's an ulnar collateral ligament, first metacarpal, or a phalanx fracture, then what happens is you'll just take the splint to the end. One nice way, you can try to eyeball it, but we tend to be too long or too short. So a nice little trick that you can use is just take your cast padding, you know the length that you want, put it distally, lay it down, just roll it sort of lengthwise, and just use this as your yardstick of how long you want it to be. You take this up, plaster shrinks about 5% when you get it wet. So take it to the length, make it a little bit longer. That's 5 layers. You double over. Now you've got 10 layers. Take your scissors. Oops, no problem. Take your scissors. And we have the plaster ready. We've got the padding ready. And what we'll do now to make him comfortable, we'll put a little box like this. Thank you. Just under there. And now his arm can just rest on this. And this will make it easier now to apply for it. Now, we've got everything ready. So now you just have to apply the splint. When you apply the splint, put the wrist in the position that you want it to be. Then when you apply the padding, it's less likely there's going to be wrinkles. We start with the padding further, like more proximal than where the plaster is going to be. So you saw the mark for where the plaster is going to be. You just go a little beyond it. The first roll is 100% overlapped. Then, with a little bit of tension on this, you have 50% overlap, and now you've got 2 layers that protect it. Always roll from the bottom, and don't pull so much here, because you'll actually narrow the padding. So keep a little bit of tension so it doesn't ripple. And what you want to do, this is the important part, to make it nice and efficient, come all the way up and cover the whole thenar eminence first. Once you've covered the thenar eminence, now you can take it, you can pull it a bit to make it narrower, and go once, twice around the thumb. You got 2 layers to protect the skin. It goes past the IP joint. Always roll in the same direction. So we're going down through the palm once and twice. We come back where? Over the radial styloid. That's a bony prominence. So we come back to the radial styloid and then tear this off. What you don't want is to just use lots of padding and make it over padded. So again, start proximally, 100% overlap, cover up the thenar eminence first, then twice around the thumb, twice into the web space, and always have a look. Sometimes there are areas that just aren't properly covered. You just need to cover them up a little bit. He's got a fairly big hand, but that's a nice way to make sure that he's properly protected. You take your plaster. We now have these 10 layers. They all have to get wet. So get it wet. And now what you want to do, just let the water run out. You can wring it together. And now what you want to do is take out some of the air, but don't aggressively strip out the plaster. The strength of this splint is the plaster. And if this plaster is in the bucket, you're losing the strength. Put this down distally. Start where you want at the IP joint. Wrap around. We don't want it to be circumferential because it's a bit harder to take off. And then just lay it down proximally. And now you can massage it very nicely into the shape that you want. Plaster conforms beautifully, much better than fiberglass does. And if it's too long, you can fold it back, Or if it's too long, it's actually quite easy just to cut the plaster when it's wet. So now it's cut, it's applied. What do we need to do now? Now we need the cling just to hold it down. Again, start proximally, roll off the bottom, and put a little bit of tension. Just keep rest your elbow on that. That'll make it comfortable. Good. And just a little bit of tension here. You want this not quite 100% tension. Back off a little bit, but some tension on the cling just to keep it nice and snug. So it comes down. You're going to wrap. Make sure you wrap the thumb. Again, right where the padding went. Wrap in the same direction. Come through the web space. That pulls everything down. You wrap around. And now what do? We've got our tape and we hold it down. So for a suspected scaphoid, a definite scaphoid, a scapholunate ligament injury, this is what we would do. If he had an ulnar collateral ligament injury, would take the plaster to the end and would put his thumb in adduction. If he had a fracture of his phalanx, would figure that one out as well, depending on how the fracture is, how you want to mold this. But for these generic scaphoid, suspected scaphoid injuries, it's really just a resting splint. He can put his arm down. We'll arm wrestle. He'll make an O. And I just put my hand here on the dorsal aspect of his wrist to get his wrist in extension. I want his thumb parallel to his forearm. And you just sit here and wait until the plaster sets. If the water's lukewarm, you'll start to feel the heat come off it. This is 10 layers. And you just sit in this position and wait for him. And once it starts to feel the heat come off, you start to feel it harden up, you can stop. It's pretty simple to put on a thumb spica splint. Understand the indications, scaphoid, scapholunate ligament. Understand the nuance for if someone has an ulnar collateral ligament injury. If they have a phalanx fracture, you got to take this a little further down. Common splint to do. Position patients in the position of function. Super helpful, and you'll make patients better for sure. Hope this helps you on your next shift.